Great. We're going to start in about 5 minutes. We're just going to give everyone a couple minutes to get on the call. Looks like 21 people are on right now. We do have 70 registered. It's about 2 minutes of 1, so we'll have a couple minutes till after 1 to make sure we catch everybody. All right, just 1 o'clock. I do want to just give a couple more minutes for those of you that are online. We are waiting for an amount of people to still join. I think no matter what, we'll start at like 1:02 just so we can get started and everyone kind of joins as we get started. So,
sure, no problem.
Okay.
Thanks so much. Is it birthday? Happy day when your CEO just gives you a piece of cake saying it's his birthday and he's sharing his cake with everybody. Isn't that nice?
It is a good day.
It's a good day. Very nice.
All right, so it's 1:02. I think we're going to get started. A few more people, they can join in as we get started. So thank you, everyone, for attending. I do apologize if my voice cracks a little bit. I am recovering. Luckily, you don't have to listen to me very long. Just a few housekeeping items before we get started. So this webinar has been approved for 1 CEU. Those will be distributed to each participant for attending the full webinar and then completing the survey at the end. The CEUs will be distributed within a week, so just keep an eye out for that via email. And at the same time, you will be getting the slides as well. The survey at the end of the webinar will pop up in a separate window, so make sure you don't miss that. When you close out of WebEx, it does pop up in a separate web window. So open the floor at the end of the webinar for question and answer with Carol Dietz. I will unmute all the participants at that time. So that's really housekeeping and introducing her. We're very excited and very grateful to have Ms. Carol Dietz partner with IPRO on the Infection Control and Hemodialysis Project and present for us today. Carol has 35 years of experience as an acute care registered nurse with emphasis on quality improvement and system development. Ms. Dietz is Qualidyme's Consulting Services Manager for hospitals. Prior to joining Qualidyme, she was the Director of Quality Improvement for an acute care hospital within Connecticut. Ms. Dietz is a registered nurse with a Bachelor of Science degree in nursing with a Master's of Business Administration degree, which she received from Sacred Heart University. Nursing career, Ms. Dietz spent many years in the emergency department, becoming the trauma coordinator for a large suburban hospital. She also spent time within several acute care hospitals as an EMS coordinator, education specialist, and nursing supervisor. So it's my pleasure today to welcome Carol. And as I pass the ball to Carol, I do want all the participants to make note of the tabs at the top of the screen. These are some of the materials Carol's going to be referencing throughout her presentation. Thank you, Carol.
Thank you so much and welcome. I hope everyone can hear me okay. I am so honored to be presenting on this very important topic of introducing antibiotic stewardship in the outpatient settings. This is a new task for us here at Qualidyme, which we are also, now we are known as the New England Quinn QIO, and I'm just thrilled that Akisha asked me to present to you today. So objectives of my presentation is to view the importance of antibiotic stewardship in the outpatient setting, and also I will also be discussing the 4 core elements on the antibiotic stewardship in the outpatient setting. I'll also discuss some evidence-based strategies to implement these core elements. I have 3 asks of the group today. The first, I expect you to memorize any of the data. I'm going to be sharing a lot of data because it's important to understand why this work is so important. So the first ask is that you actually feel the urgency of this work, and you bring it back to your facility the next time you work. And my second ask is that you feel the urgency, you start thinking about how you could incorporate these evidence-based best practices into your facility and how you could become an antibiotic steward in your facility and be a champion to work with us on this national platform. And third ask, I'm not going to tell you my third ask until the end because it's that important that I'm going to hold you to hold on like you have your white knuckles, like what is she talking about that third ask? I will ask at one of the very last slides for my third ask. Just to level set everyone, who is the New England Quinn QIO? We are Qualidyme. We are still the Qualidyme company, and we have been the quality improvement organization for the past 30 years. Ever since CM created the quality improvement program, we here in Connecticut, we have been the quality improvement organization for Connecticut. With the Affordable Care Act, Obama had said we don't need 50 different QIOs because it was all state-based. that he decided that the QIOs should become regionalized, and he only wanted between 14 and 17 QIOs in the nation, so we are one of 14. We partnered with Health Centric Advisors, who is the prime contractor for this scope of work. It's the contract, it's called the scope of work. And so we partnered with them to create the New England Quinn QIO organization, and we have experts in every setting that Medicare beneficiaries except dialysis centers. Is your expert, is your quality improvement organization. They are the ESRD network, and we partner with them on reducing HAIs. We have been working with them on reducing HAIs in the hospitals as well as in the community. So implementing an antimicrobial stewardship in the outpatient setting is brand new. We are before the contract used to be 3 years in nature. Now with the QIO, it's a 5-year contract. This contract modification, which just started in October of 2016, so this is brand spanky new. And that's why I asked Akeisha if I could do some site visits with her, because I don't know dialysis at all. It's what a wonderful setting. You give such excellent care to your patients, and I want to have a shout out to the Newington DaVita and the Danbury DaVita dialysis centers for opening their doors to us and answering. Francis is my partner here at Qualidigm. We were out there in Newington this week and Danbury last week, and just thank you so much for opening your doors and answering our questions. And that just gives us a better idea of how well this antibiotic stewardship program can fit into dialysis. And we love to have Connecticut be first in the state, first in the nation, to have all their dialysis centers sign up with us to work on this important program. So let's get on to what I'm here to really talk about. And it's all about antibiotic use and misuse and the stewardship of the antibiotics. So let's first talk about antibiotics. They are life-saving medications. We all know that. They're one of the most important advances to modern medicine. One deadly infectious bacteria diseases are now treatable, which substantially reduces the number of deaths compared to the pre-antibiotic era. Antibiotics are important adjuncts to surgeries, treatments of serious illnesses, and are critical tools in the treatment that make transplants and chemotherapy, as well as dialysis, possible for allowing us to treat bacterial infections. Antibiotic resistance is the greatest public health threats today. The CDC has estimated over 2 million illnesses, 23,000 deaths per year caused by antibiotic-resistant infections in the United States. Antibiotics are now called endangered species, facing extinction due to the worldwide emergence of antibiotic resistance. The most important modifiable risk factor for antibiotic resistance is inappropriate prescribing of antibiotics. To level set everyone on the definition of antibiotic resistance, according to the CDC, antibiotic resistance occurs when an antibiotic has lost its ability to effectively control or kill bacteria growth. An antibiotic is prescribed, its action is to kill the bacterial infection. It will kill the germs causing the infection, but there will be some germs that become resistant to the drug. These resistant germs will continue to grow inside the body and take over. So the next infection that occurs in the body, the antibiotic that was used to kill the before will not work. So a new and more toxic antibiotic must be given to kill these new germs. How does antibiotic resistance spread? It's a vicious cycle. Start anywhere in the cycle, which is up on your screen in front of you, because each part is interconnected But let's start with the animal, the cow with the pants and the fish on the right side of the screen. Start this discussion. So the animal is given antibiotics in its food to keep them healthy. And, well, then now it's going to start developing resistant bacteria in their gut. Resistant bacteria can remain on the meat once the dough is used to be processed for meat, and will continue to stay on the meat if it's not handled correctly, or if it's cooked, or if it's not cooked properly. The bacteria now spreads to the humans in our gut. All resistant bacteria will be in the animal's feces, which is used as fertilizer for the food crops. And again, eat the food crops, so now again the resistant bacteria is now in our gut again. Or if we're not eating the food, it could stay in the soil and run off into the lakes or rivers, which then contaminate the water, which now the fish live in, and then we eat the fish. The bacteria will live in our gut once we ingest all this food. So on the side of the screen, on the left side of the screen, is the hospital, the dialysis center, the nursing home, the clinic where we care for our loved ones. Out these facilities and leave behind antibiotic-resistant bacteria on the surfaces within the buildings and are not cleaned properly, or staff doesn't have proper hand hygiene etiquette, bacteria will be picked up by both the staff as well as the patients and continue to spread throughout the public. This is the concept. Simply using antibiotics will create resistance. Should only be used to treat bacterial infections. A true global issue. All countries, which includes the United States, need to have a program in place to combat antibiotic resistance. If there's only one country who is really, which is Sweden. Sweden is one of the best countries in the world for having an antibiotic stewardship national program. However, people from all around the world enter Sweden every day. They go in, they go out, so therefore they're leaving behind antibiotic-resistant bacteria. So again, no matter how hard that one country works, it's got to be a truly worldwide effort to really prevent and contain the antibiotic-resistant bacteria. Antibiotic use and misuse needs to be monitored in all settings, not just the hospital settings, but outpatient settings wherever patients are, because the primary modifier driver of antibiotic resistance, To illustrate this, let's do a brief timeline of the history of antibiotics. And this is, again, up on your screen. Which is the line in blue, you can see the year that each antibiotic was introduced, and we can overlay the date that the antibiotic resistance was first identified. You can see by this timeline that the resistance is not far behind the introduction of a new antibiotic. Bacteria will inevitably find ways of resisting antibiotics developed by humans. To prevent resistance, we really need aggressive action to prevent the resistance from developing and prevent the resistance that already exists from spreading. The goal is that every patient gets optimal antibiotic treatment, meaning they only get an antibiotic when needed, and the right antibiotic at the right dose at the right duration. Does that sound like a nurse? Adverse events from antibiotics can range from minor to severe. Side effects like a rash or antibiotic-associated diarrhea are the mild to moderate side effects, while allergic reactions, which include anaphylaxis, can be life-threatening. The CDC has reported that 1 in 1,000 antibiotic prescriptions leads to an emergency room visit because of adverse event. mean, that's huge. And the CDC also did a study and found that there was 142,000 emergency department visits per year that are related to antibiotic-associated adverse events. Is an eye-opener for me, and I did not know this. Antibiotics are the most common cause of drug-related emergency department visits for children. I had no idea. The factor that I want to address that relates to antibiotics, it's the most common cause of Clostridium difficile infection. For your patients, this could it is life-threatening if they get a C. diff infection. C. spores are prevalent in any healthcare setting. A patient or staff member may ingest the C. diff spores if there's been a piece of equipment that has been contaminated by their patient who has C. diff, has been cleaned properly, or if there's a staff member who doesn't have good hygiene and carries the spores on their hands from patient to patient. Again, in order to get C. diff, you have to ingest the spores, so it's hand-to-mouth ingestion. And I want to let you know that multiple studies have been done, and it's been found that C. diff spores can last up to 4 months on unclean surfaces. 4 months. That's phenomenal. Now the spores, the C. diff spores, are in your gut. Now, say you get sick due to bacterial infection, and your physician orders an antibiotic to get bacterial infection. The antibiotic will kill the infection and will also destroy some of the normal healthy bacteria within your gut. With healthy bacteria to keep the C. diff spores in check, the C can grow quickly and go out of control, which then causes the severe diarrhea, which can lead to death. That most often lead to C. diff infections are the fluoroquinolones, the cephalosporins, the penicillins, and clindamycin. In 2011, the CDC did a study. The CDC did a study that found that there were approximately 250,000 illnesses and 14,000 deaths caused by the CDC in the United States. But CDC, once they realized they had a miscalculation, they had to republish their numbers within the study, and now there's actually estimated 450,000 illnesses in the U.S. In 2011 from the C. diff spores and 15,000 deaths. It is a much larger issue than the CDC first thought. Some of you are saying, well, gee, why did you start to talk about antibiotic stewardship in the outpatient setting? She hasn't talked about outpatient yet. So I am. So maybe, where the antibiotic expenditures are within the healthcare settings. There was a study done using 2009 data that found that the total U.S. antibiotic expenditures in all treatment settings was $10.7 billion. This is just for antibiotics, $10.7 billion. And that 62% of these costs occurred in the community and in the outpatient settings. This followed by 34% of the expenditures occurred in the hospitals and 5% in the nursing home. It is clear that in order to tackle antibiotic resistance, we must improve antibiotic use across the spectrum of healthcare with a focus on outpatient settings. And we talk about outpatient settings. I just want to, again, level set everyone. I'm talking about emergency departments, walk-in clinics, urgent care centers, federally qualified health centers, ambulatory surgery centers, physician offices, dialysis facilities, and outpatient pharmacies. These are where providers are writing prescriptions, where nurses can work with patients, they're asking the right questions to the clinicians about, do I really need this antibiotic? Can you watch my symptoms? What can I do to help manage my symptoms at home before I take my antibiotic? There are certain things that can be done prior if it's appropriate, to be working with the physician. So we all can be stewards, and that's what I said in the beginning. We all can help our patients as well as ourselves, because we are patients at some point, to make sure that we get the right antibiotic at the right time, at the right dose. Antibiotic use and misuse has risen to national prominence due to multiple studies and reviews that have come out documenting the increase of antibiotic resistance infections. Of 2015, the White House released this National Action Plan for Combating Antibiotic-Resistant Bacteria, which contains some very specific outcomes to achieve both in the inpatient and outpatient settings by 2020. It is an aggressive 5-year plan. The goals is the establishment of antibiotic stewardship programs in all acute care hospitals and improve antibiotic stewardship across all healthcare settings. One specific goal for outpatient settings is to reduce inappropriate antibiotic use by 50% by 2020. That's a huge stretch goal, and the government, CMS, would like us to achieve that. So antibiotics are being prescribed in the outpatient setting. This is very important to understand in order to identify opportunities for improvement in the outpatient setting. According to the CDC, in 2013, providers prescribed approximately 269 million antibiotics in the United States. That's a huge number of antibiotics. If you break it down by age group, as you see on the slide in front of you, we see approximately 67 million prescriptions for antibiotics were dispensed for children, while 198 million prescriptions were dispensed for adults 20 years and older. This is truly a huge number of antibiotic prescriptions. Look at the same data, but doing it per capita, which shows the rate of antibiotic prescription dispensed per age group per 1,000 population in the outpatient setting. What we see is children ages 0 to 2 had the highest rate of antibiotic prescriptions dispensed, which decreases until the population reaches around 20 years old, and it starts climbing up again and becomes very high and peaks at 65 years of age and older. Overall, there were 849 antibiotic prescriptions dispensed per 1,000 population in the community in 2013. I think this means that there were 4 prescriptions for every 5 people in the United States. Huge. It sounds a lot, especially as I mentioned earlier, if we compare ourselves to Sweden, who has truly made a national effort to reduce antibiotic use and misuse, and our prescription disbursement rate is now to 328 per 1,000 persons. They are pushing to decrease this rate, and their goal is to have an antibiotic prescription rate in the outpatient setting to see antibiotic prescriptions per 1,000 people. That is a phenomenal goal. The map of the United States, obviously, you know what it is, and it shows the antibiotic prescribing patterns by state. 2013 data. U.S. regions has the lowest rate of the antibiotic prescribing overall, and their rate out west was 631 antibiotic prescriptions per 1,000 people, while individuals in the south are prescribed about 30% more antibiotics on average. Their rate is about 942 antibiotic prescriptions per 1,000 people. With the lowest antibiotic prescription disbursement rate was Alaska, and the highest was West Virginia with a disbursement rate of 1,274 per 1,000 population. Connecticut's mid-range, we were between 697 and 759 range. So we're right in the middle of the highest and the lowest. All variations do not necessarily indicate inappropriate antibiotic prescribing. They highlight populations for which targeted stewardship efforts may have the greatest effect. One fault of the study is that the data did not have the indications of diagnoses associated with these prescriptions. So there was a study using this data to begin looking at prescription patterns. And I don't have time to go into the study, but if you're interested in further reading about prescription patterns, the article that's on the left-hand side of your screen that was written in JAMA, which is the Journal of American Medical Association, describes the prevalence of inappropriate antibiotic prescriptions among U.S. ambulatory care visits in 2010 and 2011. And the second great resource, and I would recommend this for each facility to pull down, is a patient-friendly report written by the Pew Charitable Trust, which outlines the national targets to reduce unnecessary antibiotic prescriptions. Two excellent resources that, if you are interested, these are wonderful to have in your library. The key is working unnecessary antibiotic use in all settings to combat antibiotic resistance. That's the key to the work that we're doing. Through multiple studies and data analysis, the CDC has found that 30% of the antibiotic prescriptions are necessary in the outpatient setting, which equates to 47 million unnecessary antibiotic prescriptions per year. Not per decade, but per year. So, have we gotten any better at antibiotic stewardship or antibiotic use and misuse? I can say yes, but also say no. So yes, the CDC has found that there has been a 24% decrease in antibiotic prescriptions for children with acute respiratory infection. So they looked at one disease processes using, and they paired data from 1994 compared to 2008. So found a 24% decrease in antibiotic prescriptions for the acute respiratory infection. Overall, there was only an 8% decrease in antibiotic prescribing for the children for all diagnoses. And there has been no change in antibiotic prescribing for adults. And when there's been an increase of 30% of antibiotic prescriptions written for older adults. So it's definitely time to change. One of the major changes we are pushing forward, and what the CDC and all the other professional organizations that deal with infections have stated, it's implementing an antibiotic stewardship program in all facilities, whether inpatient or outpatient. So what is an antibiotic stewardship? What does it look like? An effort to measure antibiotic prescribing, which will improve antibiotic prescribing so that antibiotics are only prescribed and used whenever necessary. It also helps minimize misdiagnoses or delayed diagnoses leading to the underuse of antibiotics. And it also ensures that the right antibiotic dose, duration are prescribed when the antibiotic is needed. So what it actually looks like in an outpatient setting. Just so back in 2014 and 2015, respectively, the CDC released the core elements for acute care hospital antibiotic stewardship program and also for the nursing home. Both of these types of facilities are using 7 core elements for their antibiotic stewardship, stated up on your screen. So leadership, commitment, accountability, drug expertise, and tracking, reporting, and education. As I mentioned earlier, the national goal to have 100% of the hospitals implement all 7 core elements into their culture of patient care by 2020. And this map, the map of the United States, highlights hospitals that have an antibiotic stewardship program in place using 7 core elements as 2014. The darker the color on the map, the lower percentage of hospitals that have implemented the 7 core elements. As you can see, Connecticut is in dark brown. There's a lot of work to do at the inpatient level, and we are just starting with the outpatient. So we're really focusing, we're working together in both inpatient and outpatient to get this work completed. So last November 2016, the CDC released the 4 core elements for outpatient antibiotic stewardship. For my time with you, I'm going to be reviewing these 4 core elements so you have a better understanding of this national goal and how you can easily incorporate these elements into your work to reduce inappropriate use of antibiotics by 50% by 2020. So that's the national goal for outpatient settings. The 4 core elements. Now, if you wanted to pull down handouts, it's called the facility checklist, and they will go this checklist. You can go ahead and print down if you'd like, or sit and print it down later. This is the checklist that we would be working with you if your facility had decided to work with us. So it goes through each of the core elements and what's implemented in order to have the appropriate antibiotic stewardship program in your facility. So the first core element is commitment to dedication to and accountability for optimizing antibiotic prescribing and patient safety. Again, I'm going to be talking about how one facility could implement these easily, but I just want to read them through them right now. So commitment is your first core element. Action for policy and practice is your second core element, and that's to implement at least one policy or practice to improve antibiotic prescribing, assess whether it's working, and then modify as needed. The third core element is tracking and reporting and monitoring antibiotic practices and offer regular feedback to clinicians or have clinicians assess their own antibiotic use. Finally, the fourth element, education and expertise. Provide educational resources to clinicians and patients on antibiotic prescribing and ensure access to needed expertise on antibiotic prescribing. So the first core element, which is commitment, dedication to and accountability for optimizing antibiotic prescribing and patient safety. So I'm only going to be focusing on the right-hand side of this checklist, which is for facilities. The left-hand side is for clinicians, but again, I'm talking to as dialysis centers. So let's talk about what your facility could do to show commitment to this work. At facility level, you can identify a single leader to direct the antibiotic stewardship activities within your facility, which also give them the authority to implement any of these activities related to antibiotic stewardship. You can also include stewardship-related duties in a job description so that if the person leaves the job to go, let's say they want to retire, the description still holds, so the person takes on the new job, takes on the new position, will then have that job of the antibiotic stewardship as part of their job, so it will not leave if that person happens to leave the facility. You can also communicate to all your staff about this new initiative and have them all get patients to realize the new expectations of how you are committed to making sure that they only get an antibiotic when needed, not when asked for. And involved in patient care within the facility, whether directly or indirectly, can act as an antibiotic steward. And one easy way is having a commitment poster, whether it's in your waiting room, whether it's in each of where your patients sit, dialysis patients sit as they're getting their treatment. And it literally goes through, and this is another handout that you can pull down from on top of your onto the screen. This is just an example of one. We have several that we can share with you. We can add your facility name, the location. Also, if you have your champion or medical director, we could put their picture in there. And it's a very positive message to the patient that your facility is truly committed to make sure you're doing the right thing. So there's just one easy way to show commitment. This commitment poster is available on the CDC website, and the link is on the screen in front of you. It's on my slide. It's www.cdc.gov, and it's a Get Smart campaign and all the other materials. So talk about the second core element, which is action, which is to implement at least one policy or practice to improve antibiotic prescribing. You also assess whether it's working and modify as needed. One of the things that the CDC has found is that many clinicians are unable saying no to their patients when a patient has asked for an antibiotic. So one of the things that the facility could do is bring in a subject matter expert on communication techniques, which you can do as the QIO, to train staff members to communicate appropriately to their patients about antibiotic use and misuse, and why you are so committed to making sure that they get an antibiotic when needed. You can also require explicit written justification in the medical record as to why or why not an antibiotic was ordered or was not ordered. Our best practice, which we saw, Francis and I saw on Monday when we were at the center in Newington, an antibiotic logbook. That is the best practice. So that's a policy that's in place, that whenever a patient is placed on an antibiotic, the medical manager will document it, will document the physician who ordered it, and document the duration. So, and they keep track of these to see what kind of antibiotics and what kind of and why they're being ordered. So that fills this and this core element, and it also, for this, which is core element number 3, you are tracking antibiotic use, and then you want to report back on a monthly or a quarterly basis to your physicians about what type of antibiotics were ordered and any outcomes that you had seen from your patients from antibiotic use. So, and that's a best practice that we saw that's already in place. That's care of core element number 2 and core element number 3. So again, knowing Vita, sharing that with us. I went over a slide. I just went back a slide. I just want to let you know that if there are some great best practices on the CDC website, and this is the link, the www.cdc.gov Get Smart Community for healthcare providers, outpatient healthcare providers, and these are the most current, up-to-date recommendations for several diagnoses for the healthcare professionals. So you can share these with the site with your medical director, and he can poke around to make sure that his with his physicians are current to date. So this, again, this is another great site for healthcare professionals to access. Tracking and reporting, as I just mentioned, this is the third core element is monitoring antibiotic prescribing practices. Again, having that antibiotic book, that log book is a perfect best practice. And then you want to make sure you offer feedback to clinicians on a regular basis, how they're doing and if there's been a change in any prescribing patterns. The fourth core element, education resources to clinicians and patients on antibiotic prescribing and ensure access to needed expertise on optimizing antibiotic prescribing. So you can, at a facility, you can, during a staff meeting, you can provide some education to your staff, communication training or educational material. And if your facility is working with the QAO, we can come in and provide you with those resources and some education to your staff and to your medical staff. This is, again, another resource for you to go onto the CDC website. There's some excellent patient-friendly resources that can be downloaded from this site. Also, you can pull down, there's a handout that I had sent to Akeisha to have available for you, and it's antibiotics aren't always the answer. It's from Get Smart site, so you can pull that down from the top of your screen. Again, it's a very positive message to the patient and their family member about why antibiotics are not always the right choice. And these other examples up on the screen that you download from the CDC Get Smart site for patients. Poster number 1 is about watchful waiting and helping to self-manage if a physician says this is a virus, there's nothing I can do, the antibiotic cannot help you. So they call it watchful waiting, a nice explanation of what that is. And the second poster is why an antibiotic was not ordered. Again, it's a positive message. It's not making the patient feel bad, but it's helping explain why an antibiotic was not ordered. The resource, which is on the right side, it's about a specific medical condition, and this one up on the screen is for an ear infection. On the front part of the page, it talks about what it is, how it has been caused, and the treatment for it. And on the back side will help, again, working with the patient's family members on how to help manage the symptoms. The core elements provide a framework for improving prescribing for every unique outpatient facility. It's important to identify high-priority conditions that represent opportunities for improvement, to identify barriers to improving antibiotic use, and to establish clear evidence-based standards for antibiotic prescribing. This is my third ask. I know you've all been waiting for that third ask. So the first one, again, just to reiterate, you feel the urgency. You understand how important this work is and why it has to be done now. The second is thinking you are going to think about bringing some of these evidence-based best practices back into your facility, how easy it can be, and how important it is for your patient. And please know, I'm a nurse first, care professional second, and I'm always thinking about the best thing for the patient. How can I help that patient the best? I'm always focusing on patient care. So the third ask is join us. Join us in this work. And what the last handouts that are on top of your screen talks about the New England Quinn QAO Outpatient Antibiotic Stewardship Program. It's a one-pager. It talks about the benefits of joining us, what we can do, what we can provide for you. We can provide that expertise, antibiotic stewardship. We can help you. If you don't have an antibiotic tracking and reporting system, we can help you put one in place. We can help you put the right resources in place for your patients. This is the one-pager that explains it. And then the second is the actual recruitment form that needs to be signed your commitment to us, and we need 2 signatures, one from the facility administrator or your medical director, and then the other signature would be for the antibiotic stewardship champion. That person would be working with us hand in hand to either implement a new policy or put a tracking mechanism in place if there isn't one already. My third ask, please join us in this very important work. And I would love to say, if we can get all 47 dialysis facilities in Connecticut to sign up within the next month or so, we would be the first in the nation to do this. And would that be a feather in our cap? So please, please, please bring this back. Talk to the administrator about this important work. Tell them you want to be part of this work, and have them call us, email me, call me, and we will be at your door. It truly has to be a coordinated response from everyone that touches the patient. We all have to get involved in this antibiotic stewardship work, but we do it alone. We have to do it together, and we have to do it coordinated. So that's why DPH, the Connecticut Hospital Association, the ESRD network, we're all working together to help our patients stay safe within Connecticut. So with that, we're gonna open it up with questions. The very last slide has my confirmation and my phone number. I'd love to hear from each and every one of you. I'm going to go back into the question slide to see if anybody has any questions. So the phone lines have been open. If you're not asking a question, if you put yourself on mute, that would be great.
Go here to
So for me, antibiotic stewardship in the outpatient setting. I'm going to turn this back over to Arcasia and Jenna. Yeah?
Sorry, we were having issues with the mute button, so we did unmute everybody, and the background noise, we weren't able to hear people who sounded like they might have been talking, so I did remute everybody. So if you have any questions, feel free to enter into the chat, and I will ask Carol for you.
Okay. Excellent.
Having trouble hearing, so Kevin Giddings asked if we'll be sending out the information. So when you at your WebEx, all of the checklist, all of the attachments that Carol was going through are made available as long as you opt to save those attachments, and then we will be sending out the PowerPoint with your CEU. So you will have all the information provided to you. Any questions? Again, just use the chat because we did remute everybody. Not getting any other questions, but we'll leave it open for a few minutes.
Sure. Absolutely.
Okay. And if he does happen to think of something after the fact, I mean, Carol has provided her information, but you can also direct it to Jenna, and we can relay the information to Carol. So, you know, we want to answer your questions in any way that we can. Thank you. Thank you, Carol.
Oh, great. Thank you. I can't see the chat, so I apologize. So thank you. Oh, that's very nice.
I don't get any more questions, but on behalf of IPRO, we do really want to thank you, Carol. You did a great job, and I think that this is great for Connecticut dialysis facilities really get involved with this stewardship and, the country, but it'd be good for us to get a head start as well. I think this is important work you're doing, so we really appreciate you taking time to be here today and taking the time with our facilities.
Last, I am honored to be presenting, so thank you so much for inviting me. And again, anybody has any questions, I'm just a phone call or an email away. Thank you.
Thank you, Carol. So I'm going to leave the webinar open until 2. If anybody does have a question in the chat, will remain open, but if you do exit the webinar, that survey will pop up. So please remember to take that survey when you close out of the webinar. Again, it's going to be in another window, so it might look a little different than in the past. You know, it's been in the same window, but it will pop up in a separate window, so just make sure to complete that survey for us. Everybody for coming. It seems like everyone's starting to drop off now, but thanks, Carol, and thank you everybody for attending today. Keep an eye out for your email with those CUs and the PowerPoint slides.
Thank you.
Thank you.
All right.
Bye.